Good evening, America. Guess what time it is? It is 5 o'clock Central Time, which means 6 o'clock on the East Coast, 4 o'clock in the mountains, and three on the West Coast. And it is time for Fertility with Fink and Friends. I am Fink, you are Friends, and it is great to be here as we always are on Tuesday evening at this time tonight, live on location from Tulsa, Oklahoma, where I am at the Missouri Center for Reproductive Medicine, MCRM Fertility in Tulsa. You may know me as the guy from Pensacola, Florida, and that is true. I am a fertility gynecologist at New Life Fertility in Pensacola, with offices also in Mobile, Alabama, and Panama City. And I work with the fine folks here at MCRM in St. Louis and in Tulsa as well. And we're doing some embryo transfers here today and seeing all kinds of wonderful, nice people in Tulsa, where I come probably about once a month or so, and also spend a little time there in St. Louis as well. Hey, good evening to everybody. I hope your weekend was great, and that the week so far is shaping up to be fantastic. Here in Middle America, there have been, it was a very thunderstormy day. Fortunately, no tornadoes in this area, but threats of weather. Gosh, every time you turn on the TV, you see about the bad weather in all these different places, and hearts go out to all those people who are affected by things like tornadoes, hurricanes, wildfires, everything out there that just threatens our everyday way of being. But happy to see you here. This is the time when we get to talk about all those things that are important to us, things about womanhood, things about family, things about gynecology, things about getting pregnant, staying pregnant, things about hormones and the menopause, and all that other business, the business of being in families. So if you have questions, please feel free to throw them my way. Our job is to try to get to those and answer as many as we can over the course of the next hour. Let's say good evening to some of our friends who have joined here. Endopino Journey, you are number one. Thank you for being my number one tonight. By the way, we have some different feeds. This is my Instagram, and that's Randy Fink MD. We've got New Life Fertility's Instagram, which is right here. We've got a couple of different Facebook feeds from MCRM and New Life Fertility. We've got Facebook, we've got First Fertility, we've got LinkedIn, and we've got YouTube. Just so you know, New Life Fertility and MCRM are both proud members of the First Fertility Network. Kowser, good evening to you, and Angela Sack, howdy. It's good to see you, and thank you for being here as always. Logan, the therapist in Northwest Arkansas, good evening. Thanks for joining. I've got my dear friend Ocean in Miami. It's nice to see you, or at least to see your name tag anyway here. Hi, Reed. It's good to see you. Marlena is here with us as well. We've got a bunch of people over here on the Instagram and on the Facebook side whose names don't show up. So if you'd like to say hello, please tell us hello. So I had a question today about some things that I think is probably one of the coolest things that we are able to do in the whole fertility world, and that is what we call reciprocal IVF. And reciprocal IVF is when a female couple, two females, when we're able to take the eggs from one member of that couple. Typically, we use donor sperm there that they have purchased, and fertilize the egg, create embryos, and then place that embryo back into the other partner. I think that is really absolutely one of the coolest things that we can do in this entire science of IVF, and that's called reciprocal IVF. And I saw a couple of people today asking about reciprocal IVF, and I'm only too happy to help with that, because again, I think that's really a tremendous thing to do. And kind of one of the questions that I get most is, well, so what are the challenges really associated with reciprocal IVF? And I would say that, like in anything, the biggest challenge in reciprocal is dealing with the egg quality that comes from the person who's going to be donating the eggs. And obviously, the younger we are when we retrieve those eggs, the better off we will be with those eggs, the greater the probability that those eggs will be normal and hopefully create for us a normal embryo. So the biggest challenge is always, kind of in the couple deciding who's going to be donating the eggs and who is going to be the one that's carrying the pregnancy. But aside from that, the other issue is that, well, sometimes people, when doing reciprocal IVF, are interested in doing a fresh embryo transfer. And what that means, of course, is that the embryo transfer is the point at which we take that embryo and we place it back into the body of the person who is going to be the carrier. That is the person who's going to be pregnant and ultimately deliver the baby. Well, using a frozen embryo transfer is really very straightforward, because in that scenario, we create the embryos and we freeze the embryos. And as you probably know, that when we freeze embryos, it stops them in time. It allows the body to do whatever it's going to do. Those embryos stay good really forever. And you come back at some point down the line and you do that embryo transfer. A fresh transfer means when the embryo goes into the carrier, whether that's the same person who made the eggs, or in the case of reciprocal IVF, into the other partner, in that same cycle that the embryo was created. And that gets pretty challenging because we have to try to coordinate cycles between the one partner who is doing an egg retrieval and the other partner who is spontaneously cycling. So it takes a lot of logistics to try to get that to work, and sometimes it honestly just doesn't. So my recommendation is not so much to do a fresh transfer, but rather to freeze the embryo and allow the carrier cycle to be coordinated logistically, such that it's a very straightforward thing to get the right timing of putting that embryo in, because timing is everything when it comes to doing an embryo transfer. Everything has to do with the uterine lining being receptive to the pregnancy. There's a very narrow window during which a pregnancy can implant. So I think a frozen embryo transfer is usually a safer bet, just because when trying to do a fresh transfer, getting those times to line up can be a real challenge. Hi to Kim from the Facebook side. Thank you for being here this evening, and thank you for saying hello. Sarah, nice to see you here on the New Life side of things. Hi, Midgie and Florida Girl. Hey, Yachty, nice to see you. OMG Kylie and the Styles family, nice to have you with us. Kowser asks, Doctor, I have Hashimoto's with high TPO antibodies, and I'm trying to conceive naturally. Please guide me on how to reduce thyroid peroxidase antibodies and to optimize my thyroid for pregnancy. Okay, so Hashimoto's disease is also known as autoimmune thyroiditis. Autoimmune thyroiditis, or Hashimoto's thyroiditis, which was obviously described by a one Dr. Hashimoto. So Hashimoto's is when you create an antibody against your own thyroid gland. And this is a very common sort of problem. It's actually one of probably one of the most common reasons that folks will end up being hypothyroid at some time later in life, because you've created this autoantibody against your thyroid gland. Why does that happen? Why does anything in the immune system happen? We just don't really always have an answer to that. So the reason that we actually go and look for it, so the reason I look for it is because I'm looking to see, it's a Hashimoto's in and of itself really does not disturb the probability of pregnancy. All right. So It's not that there's a correlation with Hashimoto's and some disease state that prevents you from being pregnant. Moreover, we look at thyroid peroxidase antibodies and also another type of antithyroid antibody that's called an antithyroglobulin antibody. Antithyroglobulin antibody. We look at those two things along with an ANA, an anti-nuclear antibody, because I'm trying to, I think of it as standing in the doorway of your immune system and looking in to see how much chaos is going on in the room. So it's not that a thyroid peroxidase antibody or having Hashimoto's means that there's some association that's going to keep you from getting pregnant. And by the same token, when you have a positive ANA, a positive anti-nuclear antibody, it's a very, very non-specific thing. So it doesn't mean that you have some disease state, but rather what it tells me is that, okay, your immune system is fired up over something. And so we check it for that purpose, because I'm trying to see, well, really, to what extent is your immune system really fired up? And that becomes important to us when we're doing things like an embryo transfer, when we're placing an embryo back inside your body. We really want to know, do we need to be doing some sort of immune suppression or immune protocol here in order to help you sustain that pregnancy? Well, so Hashimoto's itself can be something that makes you not feel good. Now, here's an interesting fact. If you go to most medical endocrinologists and you say, I have Hashimoto's, they'll look at your TSH and they'll say, but your TSH is normal. Get out of here. There's nothing wrong with you. That's what they do. That's what most of them do. The segment of the kind of anti-aging and hormone wellness, hormone optimization community feels like, well, that's Hashimoto's thing is something we ought to treat, because the antibody can cause you to really not feel well. It can cause things like brain fog and some other stuff. There's an interesting website if you want to read a little bit more about Hashimoto's, and it's called Stop the Thyroid Madness. Stop the Thyroid Madness. And part of that is because just about anything can be blamed on the thyroid gland, but everything is not a result of a thyroid problem. But Stop the Thyroid Madness talks about how Hashimoto's or autoimmune thyroiditis is really ignored by much of the mainstream endocrinology field. As it pertains to having those high antibodies and what to do to try to reduce them, the first thing I would tell you is I would add selenium. Selenium is a micronutrient that can be taken in the form of a supplement. Adding selenium to your supplement routine feeds the thyroid and has an effect of turning down some of that antithyroid antibody. So I would encourage some extra selenium. The second thing we think is to decrease the kind of inflammatory stuff that you're eating. So from a standpoint of nutrition, it has to do with some sort of anti-inflammatory diet. Now, whether you believe that's keto or Mediterranean, whether it's kind of cutting back on the carbs and the processed foods, whatever that may be, I think that's probably a good way to do it. But the most important and most recognized way is to add some selenium there, Kauser, and hopefully that will really do the job. As far as optimizing the thyroid for pregnancy, we used to think that we wanted to keep that TSH hormone level between a 0.5 and a 2.5. And if it was outside that 0.5 to 2.5, then we would treat you with some thyroid to try to get it there. What we know now is that the evidence really does not support doing that. That the data that was originally used to draw that conclusion was found to actually be really flawed, and that truthfully, it doesn't really matter at all. Now, in my personal practice, if your TSH is above about a 3.5 and you're trying to get pregnant, I typically will treat it in that scenario. I think that's probably a worthwhile thing to do. If you're doing an embryo transfer, then sometimes we do some more stuff, associated with Hashimoto's and other autoimmune things. But I think selenium is probably the number one thing that you can do there, Kaiser, in order to try to bring down those thyroid peroxidase antibodies. Marlena is asking, I'm curious about your thoughts on embryo glue and when it is used. So embryo glue is a great marketing thing. Embryo glue is the brand name of a media that is used. It's called hyaluronic acid, and it is simply the brand name of the media that is used to kind of put the embryos in the little transfer catheter and to squirt it inside. So embryo glue is in most cases used. Places really should not be charging, in my opinion, should not be charging extra for embryo glue. It's just a brand name of the same stuff that everybody uses. Let me repeat that. It is a brand name of the same stuff that everybody uses in that transfer media. It's hyaluronic acid. It's just the brand name, and an incredibly wise marketing thing, because everybody sees that and thinks embryo glue, I have to have that because that's the only thing that's going to keep my pregnancy inside my uterus. It's that glue, right? It's really the same hyaluronic acid. So whether you're using the branded one or whether you're using a different one, everybody is getting some form of that. Now, for example, if what I mean by that is, let's say that you get a headache and you say, oh, I'm going to take a Tylenol. Okay. So you're going to take a Tylenol for your headache. Do you take actual brand name Tylenol, or are you taking acetaminophen? They're really the same thing. The FDA says they're the same thing, that there's some specific criteria by what that means in order to create a generic drug. And so generic hyaluronic acid is just embryo glue by a different name. So it's but a great, and again, I wish I had come up with it, because I think that would be gosh, we would all be in a different place right now, because I would share that wealth with you. The Friends. I am Fink, you are Friends, and this is Fertility with Fink and Friends. So you deserve it. Hello to the Bama gal. That is my beautiful mother in over there in Mobile, Alabama, and I am not on the Gulf Coast this evening. If you're just joining, I am in scenic but rainy Tulsa, Oklahoma tonight on location at MCRM. Hello, Bama gal and Harold. Reed, good evening to you. We are starting our Matching Miracles cycle. Told our egg donor has her stat day on Thursday. What does that include? So basically what that means is that is going to be the initial monitoring day for your donor's cycle. So now, it just depends on where, MCRM has a number of different kind of stat days. One of them would be a baseline. That's when she is starting her cycle, or actually before she starts her medications. So we check to make sure that the ovaries are quiet, that the uterine lining is thin, basically that the hormones are at their baseline, and that they are ready to be, the ovaries are ready to be stimulated. Sometimes a stat day is after that stimulation starts. It will become her first monitoring day. So we get a look at the ovaries. We see how many eggs, how many follicles seem to be starting to grow. We look at the hormone levels. We look at the estradiol. We look at the progesterone, at the FSH, and the LH hormone. So it tells us kind of how she's doing in her cycle. So do we need to tweak that medication, the stimulation medication, in order to maximize the yield from her ovaries? So very exciting, Reed. That is awesome, and I am super happy for you guys. Matching Miracles is really a wonderful program here at MCRM, and for those who are looking for donor material, I can't recommend them strongly enough. The way they stimulate their donors is really industry leaders. They are industry leaders in that, and the outcomes of those eggs are really extraordinarily good. The pregnancies that result much better than any other egg bank I've seen. So Reed, I'm happy for you guys, and I feel really enthused for you. Hey Shada, good to see you this evening. I didn't hear from you, and I was wondering what was going on with your cycle there, friend. So hopefully everything is going according to plan. I will keep that my fingers crossed for you there. Let's see. We've got Lisa in US. We've got Chelsea. Nice to see you this evening. Hey, Kathleen. It's Ming. Hey, Aaron. Nice to see you. Aaron from Amazon is with us tonight, and we are all very, very proud. Shadia Architecture, howdy. Angela asks here for a baseline for a retrieval. My progesterone was 3.2. My estradiol was 55. My LH was 10. Would you start stims that day or cancel? I read that a P4 over 3 can compromise the egg quality for that cycle. Well, so if I look at those numbers, I'm wondering if, a progesterone that is above about a 3 suggests to me that you had ovulated. So that means either you broke through, if you were on some hormone before that, you broke through and you ovulated, or that may mean that you're in the luteal phase and doing a luteal start is okay. Commonly, because that estradiol level is low enough that it looks like you're at the beginning of a menstrual cycle, I would have to wonder whether that was a situation where that LH was still a little high and that progesterone was still a little high coming down from the last cycle. So it just depends on if you were on medication before or if this was a natural cycle. I might be tempted to repeat that in a day or two and see if it's coming down. You were not on medication. It was day 2 of your period. Yeah, the estradiol is exactly where it's supposed to be. So that progesterone and that LH are just probably still residual hormone that's still there from your last menstrual cycle. So you check it again in a day or two, and it's showing you that it's going down in the right way, and you're good to start. I think there's no problem there. Yeah. It's Ming. Hello, Ming. I used DE and DS. The embryo was a 3-9 and beta on Monday was negative. We were so disappointed. I was on immune protocol 3. So that means that you must be at CNY because there is an immune protocol 3 at CNY. Let's see, it sounds like then when you're saying a 3-9, that means that was a day, it was a good quality day 3 embryo. So, what that tells me is that a day 3 embryo, CNY is one of the places that will transfer day 3 embryos. But in reality, what happens there is that, well, if it's a normal embryo, it doesn't matter if it's a day 3 embryo or if it's a blastocyst. Many places will wait until you have grown a blastocyst because if it grows to the blast stage, we know it has a much higher probability of being able to get you a baby. It has a much higher probability of being normal. So if it grows to blast, then we know that, okay, that has a good probability of being a normal embryo. With a day 3 embryo, unfortunately, we just don't know. We just don't know. We don't know if that embryo wasn't normal. The grading of a day 3 embryo really doesn't matter. It means, okay, it was kind of well put together, but we don't know if that embryo would have even survived to day 4 if it was allowed to continue growing. So when we do day 3 embryos, there is always going to be a higher failure rate because the day 3 embryo has not allowed nature to help select the group of embryos that's going to have the higher probability of pregnancy. Now, again, there's nothing wrong with transferring a day 3 embryo, but the success rate is always going to be a little bit lower. Nevertheless, Ming, I'm really sorry to hear. It is definitely a blow when you do an embryo transfer and don't get that positive pregnancy test. But fingers crossed that there are happier times ahead for you, my friend. You were able to make an embryo, so that is absolutely the first step in the right direction. For sure. Hey, Jessica, and let's see. Oh yeah, and so Angela's saying, "Yep, I did just that. I started my stims that day. My P4 did decrease by day 5. So yep, that was just a little leftover. Sweaters for IVF. Good evening. Nice to see you, my friend." Shada asks, "What is an acceptable progesterone range before an egg retrieval?" Well, the progesterone in particular doesn't matter so much unless you're planning to do a fresh transfer. So if you're planning a fresh transfer, then a progesterone level that's above about a 1.5 means that a fresh transfer will probably not work. But sometimes you get enough stimulation from those follicles in your ovary that the progesterone levels will start to go up. Or sometimes, if you have enough follicles, you might even ovulate one of those follicles while the other ones continue to grow, in which case that progesterone level will rise. If you are doing a freeze only cycle, then the progesterone level at the time of egg retrieval is really not important because it's not associated with egg quality. It's really just an indicator of whether that fresh transfer is going to work, because the progesterone, remember, controls what the lining of your uterus is doing. It controls that little window. It's that window of implantation. And when the number goes above about a 1.5, what it means is that window of implantation in the uterine lining is closing. But if you're doing a freeze only cycle, that doesn't matter. The only thing that matters with that progesterone level is if you were planning to do a fresh transfer. Also, at what number do we say that the body has ovulated and we shouldn't trigger? Well, if you are doing IVF, if you're doing an IVF cycle, then we will always trigger you because we are going to try to retrieve those eggs. So the trigger shot does a couple of things. In addition to telling the ovaries that we are getting ready to come for those eggs, the trigger shot causes the last stage of maturity of those eggs. It causes them to let go of the little stalk they're holding onto and to float freely in the follicle. So before we do a retrieval, we will always trigger you, no matter what that progesterone is. Now, sometimes the progesterone starts to go up. If there's been really an obvious LH surge from the LH hormone and the progesterone is high, we might want to take a look at the ovaries and see if it looks like, gosh, we missed the window and all the follicles are collapsed. But you can't always tell from looking. Unfortunately, you kind of have to go in and put a needle in and try to withdraw an egg in order to see really what's going on in there. Hey to Jessica Sepp, good evening to you. Chris and Lena, does acupuncture have any benefits or downsides if you do it before an FET? And the answer there is there's no downside, and there's some people who swear by their acupuncture. So there is a specific protocol for pre and post FET acupuncture that you can do on that very day, provided that you have an appropriate acupuncturist to do one just before the transfer. You do your transfer, and then you do one just afterwards. There is absolutely no downside to it, and there are many people who swear by it. According to the American Society for Reproductive Medicine, there is not sufficient enough data to recommend that everyone do this, or to say that it is absolutely beneficial for everyone. But again, if you have access to a good acupuncturist, then there is certainly no harm to it. And and it just may help. Hey to Lisa Swearingen in St. Louis. Thank you for being here this evening. She sends a heart to everybody out there. Lisa works at MCRM in St. Louis, and it's great to see you here. Hi, Lee. It looks like Lee 09889. Howdy. Is it Lee or Lay or I think it's Lee. Hi, thank you for saying hello, and to Deb Villa Jones. It looks like that says I can't quite see that far. Raquel Castelli, nice to see you here this evening as well. Oh, let's see what else is going on here. If you have a question, please throw it my way, because our job is to talk about all these things that are important to us about making families, about fertility, and about women's health. Let's see. You know what? It's half past the hour, which means it's time for a very important segment of my show, and that is what we call the 5:30 Fuzzies with Fink. If you're in the mountain time, well, it's really the 4:30 Fuzzies. And if you're out on the West Coast, then, oh gosh, then it's really the 3:30 Fuzzies, but the half past Fuzzies with Fink. And what is that? That is the time that we all take a moment out of what we're doing and send our thoughts to everyone tonight who needs a little extra help. To everyone who needs to know that they are not alone, and that the troubles, the anxieties, the fears, the difficulties that they're dealing with in their life right now are something that we have all experienced. And most important to know, we are not alone. If that has to do with fertility, this for sure is a lonely and frightening process that often occurs without the guarantee of what's going to happen on the other side of it. And that's a big anxiety provoking thing. Those of you who have been through it understand that the troubles, the difficulties that this can lead to in your life can make you feel very lonely and really very, very frightened indeed. If we had the ability to stand together as one community and send out all the best, most positive vibes to everybody out there who's dealing with fertility, who's dealing with problems with family, with relationships, boyfriends, spouses, loved ones, who's dealing with issues over work and over school, and all those hiccups, all those speed bumps, all that turbulence that life throws to us. If we could do that together, then maybe we could break the internet with a little kindness and let everybody out there who needs it know that they are not in this alone, that we are all in this together, and that there will be happier times ahead. As I am fond of saying at the end of my show, tomorrow is a new day, and it's full of all new adventures. And I really do believe that. So every step forward with hope. And that, my friends, is the 5:30 Fuzzies with Fink. Send out those positive vibes right now. And please make sure that you join me next week at half past. Get all your friends to join at half past, even if it's just for a minute or two, because the more people we have who can send along those vibes, I really do think the greater the probability we have to be able to change the world. And what better thing can we do? Not enough kindness out there. Deb from your old patient in Miami, thank you. It's so nice to see you. And Lady, that's who that is. That's Lay. Okay, Lei is Lady. Thank you, Lady. And Deb, it's so good to see you here tonight. Lady says, my daughter had a gastric bypass last year, and she is currently 5 weeks pregnant. Can't keep anything down due to extreme nausea. What do you recommend? Well, so, the first thing is with that gastric bypass, you're dealing with really two different concerns. You're dealing with one, an issue where the stomach itself has been made smaller. So by necessity, stuff that's going into the stomach, if extra stuff goes into the stomach, it wants to come back up that direction. So you've got a physical portion of a problem there. And at the same time, you've got the hormonal aspect of the pregnancy that's also causing that sort of nausea and vomiting. There is medication, and I would, lady, strongly encourage her to talk to her doctor about that, because there are several different kinds of medications that we can use to treat nausea and vomiting in pregnancy, but she is at a really a particularly high risk to experience that. And that can be associated with some, not only the unpleasantries of nausea and vomiting, because, I always say little kids can puke and be back outside playing in 20 minutes. We are nauseated and we are on the couch for the day. Adults don't do well with nausea. And so there are some very straightforward and easy things she can do, and there are some good prescription medicines that she can use. But really, I would suggest she starts to seek care for that as soon as she can, because the quicker you can get on top of it, it is way better to prevent nausea than it is to be nauseated and to try to make that go away. Now, for general nausea and vomiting in pregnancy, I always say it's easiest, you keep things in your stomach as best you can. That may be a pack of crackers. That may be just a little something that you eat over the course of the day, because it's when your stomach is empty. Oftentimes, that's when the nausea is worse during pregnancy. And the reason they call it morning sickness, and anybody who's been through it knows, it's not just in the morning, but you wake up with an empty stomach, and so then you can be nauseated. In that scenario, keep some saltines by the bedside, and if you get up to go to the bathroom at night, just munch on a saltine, have a little something in your stomach. Forget about what your weight, and oh gosh, you don't want to eat the carbs associated with that saltine cracker or the Triscuit or whatever. Not important at that point, because with all that nausea and stuff in pregnancy, it's really about survival mode at that point. So, yeah, feel pretty strongly about that. Hi, Rosa. Good to see you this evening, and my friend Pui in St. Louis with the most wonderful restaurant ever, and that's the Sushi Station. If you're in St. Louis, please go see Sushi Station and go see Pui, because she is a wonderful person, and that is a great place. One of my favorites. Logan, thank you for being here as always. Logan says, don't let the hiccups cause you to drown. There are so many small wins throughout. It's just hard to see sometimes when you're in it. You're absolutely right. It is you got to be able to see the forest for the trees. Infertility is a hard journey, Logan says, but you are stronger. And I think that is very, very true. And another thing, actually, Logan said at one point that has really stuck with me, and that is, kind of be gentle with yourself, because it's easy to let all of your past kind of catch up with you and let your mind kind of lose control over everything that you've ever felt bad about, every decision that you've ever made, feeling like it has brought you to this point, or that you're getting something that you deserve, or the shame, or whatever it is, whatever that evil motivator is that sits up on your shoulder here. To be able to quiet it down is really is truly a gift, and that's where therapy can be very, very helpful. Be gentle with yourself, and realize, many small wins. So celebrate them for sure. Let's see what else we got going on here. I was also asked a question about sperm morphology. Sperm morphology. What is sperm morphology? Morphology means the way sperm look under the microscope. So somebody's job is to sit in a microscope and look at sperm all day long. They look at heads and necks and tails of sperm. So I always say, God bless them for the work that they do. That's a tough job to stay focused on that. But one of the reasons that we as human males are so inefficient at the way that we reproduce is because what's normal for us is that 96% of the sperm will look abnormal. That's right. 4% normal sperm is all we expect when we look at sperm under the microscope. 4% normal, 96% of them are abnormal. The other reason, since we're talking about it there, is, so we say in general, you need about 20 million sperm in order to reliably put one sperm on target. The other reason for that is because we may find that only 30 to 40% of the sperm are actually swimming, and that's called motility. So with 60 to 70% of the sperm not swimming and 96% of the sperm looking abnormal, it's no wonder that we need 20 million sperm in order to put one sperm to work. But morphology is not a cause. When someone has a lower than normal morphology, we have a term for that. It's called teratospermia. And it's not a cause of infertility, but it is an association with couples who are having subfertility or who are just having issues. What does it mean? It means that, well, there may be a little smaller cohort of sperm who know how to get there and actually get the job done. When I see persistent teratospermia or a low morphology, it makes me wonder about what we know of as DNA fragmentation. What is DNA fragmentation? Well, we know what a sperm is. It's a little package of genetic material with a motor on it, right? It's DNA with a tail. The DNA in the sperm live in the head part of the sperm, and we can't actually see that DNA. We can't see that genetic material, but we look at it, and really what we see is the motor. We can do a test for DNA fragmentation. And what DNA fragmentation means is that when that genetic material that's all kind of rolled up in there starts to sort of come apart. When I see an excessive degree of low morphology or of teratospermia, I start wondering about the level of DNA fragmentation. And when you have DNA fragmentation, it doesn't mean that that abnormal sperm gets you an abnormal baby. Really, what it means in most cases is that the sperm just don't know what they're supposed to do. They get around the egg, they hang out around the egg, they're like, hey, how you doing? But they don't know that they're supposed to be knocking on the door and able to try to penetrate that egg in order to fertilize it. DNA fragmented sperm is sperm that just doesn't know how to behave around the egg. So in that scenario, that often causes a decrease in that sperm's ability to naturally fertilize an egg inside the body. So in some scenarios, a high degree of DNA fragmentation means that that we may recommend IUI instead, or in some cases, that fragmentation can be significant enough that even IUI is probably not going to do it. And the actual treatment for DNA fragmentation in sperm is taking one sperm and placing it inside the egg. And that's a process known as ICSI, ICSI, and that's what we do in IVF. We rev up the ovaries, get as many eggs as we can get, take one individual sperm and place it inside each individual egg, and that creates your embryos. So ICSI is the ultimate solution to DNA fragmentation. But when someone is asking about morphology and the reason that we test morphology, not a cause of infertility, but certainly an association with couples who are having a hard time getting pregnant. And the reason for that is because it is associated with higher levels of DNA fragmentation. So how do you do a DNA fragmentation test? Well, it is simply another semen analysis, but this is done through a particular laboratory. Now, at MCRM, as part of the what we call a magnified semen analysis, every male undergoing a magnified semen analysis is going to have a test performed that's called the HALO test, and the HALO is a test for DNA fragmentation. In other scenarios, if you've done a basic semen analysis, then we may suggest a DNA fragmentation test. And that's usually a kit that's sent to the home along with some dry ice, because you collect it at home and you pack it up in the dry ice and you send it back to the company and ReproSource, and they run this test for DNA fragmentation. The results come back technically speaking, is one of three different things. It either comes back, it gives us a number. If the number is 1 to 19, that's considered normal. If the number is 20 to 29, that's considered borderline. And if the number is 30 or above, that is considered abnormal. Now, in reality, if even if it's in the borderline range, it may mean that spontaneous conception or conception inside the body has a significantly lower probability of working. So, depending on what that number is, we may tell you if we find DNA fragmentation that really IVF is the best option. Now, some people will say, well, but I don't want to do IVF. I want to do IUI anyway, or I want to do a timed intercourse cycle anyway. And I would say, you certainly can do what you wish, but I would tell you, in my experience, with a high level of DNA fragmentation, I don't know that I have ever really seen a couple conceive the normal way. And so when we suggest, gosh, do you do something else? There really probably is a reason for it. What Angela asks, what if it's 54% for DNA fragmentation? That's very high. And so there's really a couple of things that I would do for a guy with DNA fragmentation at 54%. First of all, that's male factor, and that needs IVF. That's not something that an IUI is going to work for, and certainly not inside the body. I would use some alpha lipoic acid, or also known as ALA, or sometimes called R alpha lipoic acid. That is a supplement that you can get at any drugstore, and it's 600 milligrams. And that certainly has been shown to improve DNA fragmentation. And the other thing that I would do is that, well, before we did the fertilization, when he did the collection of sperm for your IVF, I would say, I want you to increase the frequency of ejaculation, because increasing frequency of ejaculation will decrease the sperm count, but it will improve the sperm quality. So, three straightforward things that I would do in that scenario. Rosa asks, is omega-3 okay to take while breastfeeding? And the answer is yes. Omega-3 is fish oil, also called DHA or EPA. Now, you may also see DHEA. DHEA is not DHA. That's something completely different. So don't make that mistake. But yes, omega-3 fish oil, absolutely safe to take while breastfeeding, and something that I would actually highly recommend, because we know that babies of moms who are taking omega-3, and those who are, who are taking omega-3 while the baby was on the inside and then while breastfeeding, will have higher visual acuity scores, so their eyesight does better. And that's because that same type component that makes up the fish oil makes up the retina in the back of the eye. And secondly, they'll also have higher cognitive scores. That same type of phospholipid, as it's called, is what that cell is called, is what makes up brain tissue. So, yep, omega-3 is definitely a good thing, Rosa, especially while you are breastfeeding. So let's see what else here. Marlena asked, if you do ICSI and your fertilization rate is low compared to the number of mature eggs, what is the cause? Is it sperm? Is it egg? Or is it both? Well, hard question to ask there. So let's say that you get 10 mature eggs and you go to fertilize, and maybe only 2 of them fertilize. That low fertilization rate, the first thing that I start to think about is a sperm issue. Is there something about the sperm that's preventing that fertilization? Now, the embryologist can also sometimes clue us in and give us more information about the eggs, because they may look at the eggs and say, well, qualitatively speaking, these eggs just don't look good. They may be dark and granular. They may be kind of starting to come apart, degenerating, or the membranes around the egg cell itself may be weak. They may be able to tell us something about that. So it certainly can be both, but more often than not, when it's an egg issue, you see fertilization. You just may not see those embryos continue to grow. So, certainly, if they stop growing by day 4, that is almost always considered to be probably an egg issue. But, Marlena, if you're asking about fertilization, not seeing enough fertilization, we start thinking about this as potentially being a sperm issue and wondering what else can we do about that. And that, as we were just talking about DNA fragmentation, is actually something that we do see. And so, what can you do in that scenario? Well, then the next time that you go back to get sperm, sometimes we'll see that, and it's with donor sperm. And in that scenario, we say, you know what? I think you're going to be better off choosing a different donor. Or, as the case may be, we may say, okay, well, we didn't get luck this time. We're going to have to do this again. So I'm going to suggest alpha lipoic acid. I'm going to suggest increasing the frequency of ejaculation. And sometimes what we know is that getting testicular sperm directly from the testicle through either usually through an aspiration or something that a fertility urologist specializes in, will be something that can solve for that issue. So it gets a little technical, Marlena. We kind of have to look at all the factors there, but most of the time we can make a recommendation on what can we do to overcome that problem. Because much of the time, as you describe it, that is a sperm issue. Yeah, absolutely is. Hey, to Lauren Lucas, good evening. Happy to see you here with us tonight. If you are just joining, this is Fertility with Fink and Friends. I am Fink. You are Friends, and we are live tonight from Tulsa, Oklahoma, at MCRM Fertility, where I am here seeing some wonderful patients and doing some embryo transfers over the next couple of days. I'll be back in Pensacola on Thursday to see all my friends because we have a cycle of IVF starting up really soon. If you're involved in that cycle, I hope you are as excited as we are, because that is really, kind of what we do best. Just went through a wonderful period of going through folks and getting a bunch of positive pregnancy tests. It doesn't work every time. And one of the most important lessons that I've learned that I try to teach all of the younger generation, the residents and the younger doctors who will sometimes come along to watch, is that we do our very, very best for people. We really, really do, because what we want more than anything is to make people happy, is to give people those families, and really to see those positive pregnancy tests. And I know that I can't always do that in my capacity, that I'm not able to help everybody. And it's a hard realization to come to, but we know that it's not going to work 100% of the time. But even if it doesn't, what makes the difference to me is that person knows that I have given them 100% of my personal, undivided attention, that I personally have done everything for them that I am humanly able to do to get them that baby, and that my staff, God willing, is as nice and is as kind and is as empathetic and is as giving to them, so that they know that we have tried our best. That's really what we can do. So we can't get to 100%. It just doesn't work that way. But to know that we've tried really is what makes the difference in my world. Logan says, yeah, I've stopped calling it normal conception and started calling it magic. That's true, because honestly, how many people are doing just that? IVF doesn't make you any less normal. Your path is just different. And I'd say 100%. Yep, that is completely true. And sometimes I think I probably do use that term normal conception, but I'd say conception inside the body by one means or another. IVF is just another tool in the toolbox that we have to help you get where you need to go. Marlena says, hope to join the positive bunch in a few months, starting my Oralissa in a couple of days. So Oralissa, for those who don't know, is a medication that we can use to suppress endometriosis. So endometriosis is that process where that uterine lining that normally goes out the door, instead of going out, works its way up to the inside and implants in sites inside the pelvis. And it can do several different things. It can cause a pain syndrome. And indeed, the classic presentation of endometriosis is pain. It can cause scarring on the inside and disruption of the normal anatomy. It can cause your ovarian reserve to be low. It can collect in the ovaries and create a big cyst that needs a surgery. But we also know it can interfere with the way a pregnancy implants inside the uterine lining. It creates a system that opposes, that blocks the effect of your own progesterone hormone. And that progesterone is really the most important hormone that you need for maintaining your pregnancy. So what we know is that if we suppress that endometriosis, if we can turn it off hormonally for 60 days before doing an embryo transfer, then we have a very significant impact on being able to help that pregnancy stick. So what Marlene is talking about there is her suppression with Oralissa. There's a couple of different medications that we can use for that suppression. One is Lupron. Lupron is a shot that literally shuts off your hormones, pulls the plug on them, puts you into a temporary menopause for 2 months. Oralissa is a pill version that seems to be a little better tolerated. It has a lower side effect profile. So that's kind of a nice thing. There's another medication called Myfembry, which is not as well studied, but that's how we do it. That's how we suppress that endometriosis. And that's what Marlena is working on. And our thoughts are with you. You're hoping to join the positive bunch. Well, you stay positive even right now because you are doing the right thing. I want you to know you are taking steps towards getting yourself pregnant. This is not lost time. You are actively doing something that's going to result, God willing, in your ability to have that baby. Folks, we are going to be out of time tonight, but I sure am pleased that you were able to join me, and I appreciate it so much. I'll be back again next week from Pensacola, tonight live from Tulsa, Oklahoma. Just remember, this fertility business, it's not the book of your life. This ain't your novel. This is just a chapter. And what are we doing? We are here to rewrite that thing together. So every step forward with kindness, every step forward with love, and most importantly, every step forward with hope. Because tomorrow is a new day and it is full of all new adventures. So until next week, Dr. Randy Fink saying thanks so much for being here and good night.